Good evening and welcome back to the Canadian Concussion Center's webinar series, which is sponsored by LIUNA, the Laborers International Union of North America. My name is Leslie Rattan, and I'm pleased to be moderating our webinar series that was developed for individuals that have sustained concussion, their caregivers, as well as healthcare providers. And if you've been with us before, you know that our sessions focus on various aspects of concussion. And we start with generally about a half hour or so presentation from an expert speaker. And then that's followed by a chance for you to get any questions that you have answered. Our sessions recur every other Tuesday evening at the same time. Just before I go on any further, we also like to begin by acknowledging the Indigenous peoples of all the lands that we're on today. Even though we're meeting virtually, it's important to recognize the lands we each call home and reaffirm our commitment to improving relationships and understanding with local Indigenous peoples. From coast to coast, we honor the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. Just a couple of housekeeping items. So for this evening, if you do have any questions for our speaker, if you just sort of move your cursor, you'll see that there's a Q&A box at the bottom. So that's where we would ask that you enter any questions that you have. If you're having any technical difficulties, you can enter those into the chat, and Christian can give you a hand. Okay, and we also just like to run a very short poll every webinar just to get a sense of who is in the audience. So I'm just going to give a second for Christian to pull that up, and if you could just let us know who you are, it's helpful for us. Okay, so I'm really pleased this evening to welcome back Dr. Andrea Para. Dr. Para obtained her master's degree in medical biophysics and a medical doctorate at the University of Toronto, followed by residency in diagnostic radiology at Western University and diagnostic neuroradiology fellowship at Yale University. She is now a diagnostic neuroradiologist in the Joint Department of Medical Imaging and an assistant professor at the University of Toronto. Dr. Para's interests are in advanced neuroimaging, medical education, and quality improvement. Her focus is on the clinical application of advanced neuroimaging techniques such as CVR, MRI perfusion, functional MRI, quantitative MRI, and artificial intelligence. So with that, I am going to turn it over to Dr. Para.
Thank you, Dr. Rattan, so much for having me here to speak today. So my talk today, I'm going to talk about imaging from the perspective of a neuroradiologist and how do we look for signs of concussion on imaging, what are the various imaging modalities, and kind of where is the future headed in terms of research, and is any of that research now being translated into clinical use? So I don't have any disclosures. I got a bit ahead of myself. As I said, we're going to look at the various imaging findings in concussion and traumatic brain injury, look at various advanced imaging modalities, and then talk about how do we apply this to patients experiencing concussion today. So the brain, as we know, is a very complex structure with multiple interconnected components, including neurons, glial cells, microglia, oligodendroglia, and blood vessels. And when somebody has a blow to the head, there's physical effects on the cells in the first line that result in functional effects down the line. And if the injury is severe enough, you can become unconscious due to widespread membrane depolarizations where the neurons can't fire. And then they can repolarize, but there could be microstructural injury. This might not necessarily be apparent at the time, depending on the imaging modality. And then if we have even more severe injury, then that's where we can see things on imaging acutely, such as hemorrhage within the brain. But all these different cell types can be affected in, well, let me get my laser. All these different cell types can be affected in different ways, but all the processes of these cells are interconnected and in the end can ultimately cause neuronal dysfunction. So after a head injury, as I said, we can see dysfunction on a cellular level. And if it's severe enough, where we think of more of a traumatic brain injury or a more severe type of injury, where the cells are so badly damaged that it results in cell death. So classically, this can be thought of as microstructural injury and macrostructural injury. And when we have macrostructural injury, it's big enough that we can see it on conventional imaging, where we can see signs of bruising or bleeding or edema in the brain. Whereas microstructural injury, which is typically associated with concussion, is a lot harder to see. And we're going to go through some of that. So thinking about traumatic brain injury, where the insult might be a little bit more severe, most of the injury is a result of shear and pressure forces. So this is a neuron, and we can see that there are very long, thin axons that connect then to other cells. And this axon is what is very susceptible to injury when there's that sudden jarring force associated with when the head hits something. And this injury is called diffuse axonal injury, or sometimes shortened as DAI. And if we see this on MRI, we can see microbleeds where this sequence is sensitive for blood. So these black little dots are little microbleeds. Or we can see contusions like here, where the cells have actually died. And now this is just an area of CSF and there's no more tissue left there. Sometimes we can also see little dots of white matter, little white dots in the white matter. And these can be challenging because they can be associated with some of these injuries, but we can also see them in a lot of other conditions. So it can be really hard if we don't have a image from before the injury to say, is this because of the injury, or could this be related to something else like high blood pressure or diabetes, or even sometimes people with migraine get these dots. So it can be very challenging to sort those out. Was this related to the injury or not? So in studying these changes seen after brain injury, looking at those areas of volume loss in the brain, sort of like in this one, we can tell that the brain was kind of bruised because it hit the skull and then it resulted in this loss of tissue. But what they've also found is that if we look at the volume of the brain right after the injury and then come and look at the total brain volume a year later, people who've had a concussion show more brain atrophy or just kind of generalized volume loss throughout the brain than compared to people that haven't had a brain injury. And then there's some areas of the brain that can tend to see slightly more volume loss than other areas. And this was seen if following people at 5 months and 20 months post-injury. So when we're imaging concussion, we do know a few things that occur, but we know that like the certain things that happen like hemorrhage, or if there's been the contusions or the loss of brain volume. But then we don't really have a good understanding of the functional consequences and why that is translating into patient symptoms, or why conversely, maybe somebody might be having severe symptoms, but then we don't see anything on MRI. And the main limitation is that imaging is focused on that macro structural or larger picture of the brain, whereas the damage is probably happening at, well, it is happening at a smaller, more microstructural level. And then these changes might take time to develop. And if we're not imaging at the right time, we might not also be able to capture it fully. So people have tried a lot of different techniques to better understand concussion and traumatic brain injury, including FDG PET, SPECT CT, functional MRI, EEG, and magnetoencephalography. And all these advanced imaging techniques have been able to differentiate some findings in patients with concussion and brain injury compared to normal controls. But a lot of the times you need a lot of people and you need to kind of average the findings across a large population. Whereas if it's just one person, it's very hard to pick out, like just from the imaging alone, does this person have a concussion or not? Yes or no? And it's not able to be specific enough for one individual person at this time. So concussion is fundamentally an imaging problem where severe injury is easy to see, but concussion is very difficult. Structural concussive injury is microscopic and sparse, and we're looking for small changes in a vastly complex brain with billions of neurons. Just like an astronomer looking in the universe with 100 billion stars, it's become easier to find new planets with powerful telescopes and computers. So the hope is that with advanced imaging techniques combined with powerful computing, that we'll have the tools in the future to make better pictures and better understand concussion. So when I was talking about microstructural injury, this is a pathology specimen, and this is less than 1 millimeter wide. And the little black areas here are, I think, were hemorrhages related to prior concussion. So we can see damages on a microscopic level, but this is less than 1 millimeter. And then when we look on traditional MRI, the pixels, or the 3D pixels, which makes the MRI images, typically 1 to 3 millimeters. So we just, even with our best, strongest MRIs, we don't have the spatial resolution that we would looking at a pathology specimen. And so we're basically looking for kind of like a very small needle in a large haystack. So what can we see on imaging? Let's start with our conventional imaging, and then we'll move to kind of some of the more research and advanced imaging. So on CT scan, most people who have an acute injury, like say in a car accident or a fall, would end up going to the emergency room to be assessed and commonly would undergo a CT scan. So in concussion, by definition, a CT scan would be normal. If there's something more seen on it, like a bleed or a fracture, this would be considered more of a higher grade injury, such as a traumatic brain injury. But concussion, by definition, on CT should be normal. But then we know that CT doesn't see everything, so we can look at MRI, and it's one of our best imaging tools that's routine clinically available to assess the brain. And on MRI, concussion also falls within the category. Most people with concussion are going to be normal. That being said, about 30% of patients who have a normal CT and a GCS 15, that's a Glasgow Coma Scale of 15, it means that they never lost consciousness and they were fully alert and oriented. About 30% of those patients would have a finding on MRI, such as those microbleeds or contusion or some other finding. So those people would then be diagnosed with a traumatic brain injury. But all in all, of all the people that we scan, most people with concussion would be normal. Some people, we might find evidence that actually it was a bit more of a severe injury. So in studying people on MRI with concussion, the images were reviewed for those white matter dots that I was talking about before. any evidence of prior injury that resulted in scarring or atrophy in the brain, and then any evidence of prior bleeding. And 97% of the patients in this study had normal scans. The presence, as I said before, of any of these more severe findings would then suggest that the diagnosis should actually be a traumatic brain injury rather than concussion. So the imaging can help us to rule out any larger injury. But then in those people that the imaging is normal, it doesn't mean necessarily that they don't have a concussion. It's just we're kind of ruling out that maybe something more severe could have happened. But it doesn't tell us yes or no, there was concussion. It just says, no, we didn't see any more severe form of injury. So then those are kind of the two workhorses of clinical medicine as it stands now. And so now I'm going to talk about some of the modalities that are being investigated on more of a research basis. So SPECT is single photon emission computed tomography. And for this study, a special radio tracer is injected, which measures blood flow. And this is commonly used in other diseases such as epilepsy and dementia. And in those, we are looking for changes in blood flow pattern in the brain. So in healthy patients, the problem is that there's a lot of variation in what a normal person can look like. So if we're looking for very subtle changes in blood flow, it's very difficult to know if it's related to the concussion, or it could be related to something else like a medication that the patient is taking. So while we can see these changes if we average them over many patients, it's very hard to apply it to an individual patient. And when you're looking at these images, a lot of the reading is a bit more subjective than objective, which can also make it hard to apply at every hospital across the country when you don't necessarily have that expertise at every hospital. So in a study of patients with mild traumatic brain injury, they studied 43 patients and they found that about half of them did have abnormal blood flow on SPECT, compared to only 9% having abnormalities on MRI or 5% on CT. They found that these changes could be seen very early after the injury, at about 24 hours after injury, and persisting for up to 3 years. But as I kind of alluded before, the interpretation can be very difficult. And people who are included in a research study, sometimes they're picking people with very strict criteria who might not have other medical conditions. But when we look at the whole population, everybody, could have other medical conditions like migraine or depression or post-traumatic stress disorder. And it's known that they can result in changes in blood flow as well. So then when you see this change, it's really, really hard to know, was this because of the concussion, or is this just because they're a normal human being and they have other factors in their life and in their health history. So the main issues with SPECT then are that it's somewhat subjective assessment, looking at those color maps of the blood flow. And for this to really move into routine clinical use, the best thing that we could do is kind of standardize the protocols that are being used between different institutions, and try and use more of a quantitative analysis to make the assessment more objective rather than subjective. So you can do this by looking at a large group of people to try and understand the range of normal that exists within the the broader population, and then consider using some statistical cutoffs for calling findings either normal or abnormal. So we can do this broadly for a lot of different imaging techniques. And we usually, think of it as building an atlas that we can compare to, where we can average all the brains of many people together to kind of understand that range of normal, and then understand when we see the patient, where do they fit in relative to this normal population. There is one company for SPECT that has been developing this software, and they basically break the brain down into different anatomic regions, and then they will give the measure of blood flow in each of those areas compared to the normal control, with the statistical values along the bottom here. So for this person, we can see that compared to normal, they're between 2 and 4 standard deviations below normal. And generally, more than 2 is considered more likely that the finding is real and not from chance. So something like this, I think, would really help to make it be able to be implemented at many centers. But then the drawback is that a lot of these softwares that are being developed are for-profit medical companies, and then there's costs associated with using the software. So it really limits the ability to have this kind of widely adopted outside of kind of maybe specialized academic centers or research centers. There's also interest within SPECT of using different radioactive tracers that might be more sensitive to different types of changes in the tissue. So this new tracer, I'm not sure how to pronounce it, Clindine, and it is associated with increased microglial activity. So it binds to a protein that is increased during inflammation when the brain is trying to repair the injury. And it can be elevated for within a week to 2 weeks of injury, and persist for several months after injury. And it has been associated with correlating with the severity of patient symptoms, which is also very interesting. But again, this has been done on a research basis. This tracer is not widely available, and it also hasn't been validated in a clinical trial. Like, things would have to be approved by Health Canada, for example, to be widely used in Canada. So there is encouraging work being done out there with these new tracers and quantitative methods. But again, we're still not quite there yet. So are there any other advanced neuroimaging techniques that can do a better job? So there's a couple of things the collective radiology community has been looking at. One is measuring cortical thickness and, in general, brain volume. Another is diffusion tensor imaging, where we're looking at those long fiber tracks within the neurons, and looking at the different injuries that happen to them and how that changes the cells, using functional MRI to look at resting state connectivity, or using CVR to look at the effect of injury on the blood vessels, and then how does that affect the brain. So in volumetric imaging, there is evidence that after concussion, people can have more brain volume loss over time. So this is an example of a very high resolution 7T MRI. And it's beautiful because you can get really great images of the brain that almost look like a pathology specimen. But the difficult thing is that these MRIs are very specialized and very expensive, and they're not routinely used in clinical imaging, and they're not widely available. So it might be good at a dedicated research center, but again, in terms of giving availability to all the patients, we just don't have enough of these equipment. And that's not even just in Canada, it's like even in the US, there's very few centers that have these specialized MRIs. But as I said, that we can see changes in brain volume, And particularly in the hippocampus, which is responsible for memory, there have been some studies saying that that area can be affected a little bit more than others. But again, this is small research studies and hasn't been validated in larger populations. Another study looked at brain volume loss over time, and this study looked at people who had served in the US military, and they'd been exposed to things like firing ammunition, and it was the repetitive blast or kind of bang or boom from that that they were exposed to. And so these people were probably exposed to more events over time than somebody who maybe just had like one incident. And so these people are potentially at higher risk due to essentially kind of multiple concussions over time. And these people showed over time that there was more brain volume loss compared to a normal healthy population. So when they looked at the rate of as people got older, the normal healthy group, when you average everybody together, this was kind of the normal rate that there's atrophy over time as people get older. And then in the people who had concussion, that slope was a lot steeper and they lost more volume over time. Sorry, so one more point about this is when we see each of these dots as being a single person, we can see how there is a lot of scatter in the data. And it would be a lot easier if all the blue people were kind of clustered down at the bottom and all the yellow people were clustered at the top. But there's a lot of overlap between these two groups. So it means that if we just have one dot and we don't know where the rest of the dots are, it's very hard to tell where this individual as one person fits in. And so the main problem with these studies is that when we look at a large group of people, we can see these subtle changes. But again, it's really hard to extrapolate that backwards to if you're this one person, what does this mean for you in the future? So another technique is called diffusion tensor imaging, and we do this on MRI, and it measures changes in the tissue based on how water moves, and if the disease, or in this case, the concussive injury, disrupts the normal biological barriers and impacts how the water moves through the brain. So this is a picture of a celery stalk, and then this is the picture on MRI. And basically we can kind of think of the celery stalk like a neuron, like it's this long kind of stringy vegetable that's full of water. And, you know, if you put it in a glass of water, the water would go up the stalk to the top. And that's kind of how water would move through that long neuronal axon. And so here we can see, using the special imaging technique, we can see those channels where the water is moving through the celery stalk. And so when we apply this to the brain, we can see all the various fiber tracks in the brain and which different areas of the brain are connected. And then we can calculate a whole bunch of different parameters based on that. And the most commonly studied parameter is called fractional anisotropy, but some of these other parameters, you'll see them in lots of different research studies as well. So in a study using DTI after sports concussion, this study looked at people who had multiple head injuries, but they were considered to be subconcussive. So people who didn't lose consciousness, didn't need to be removed. But you can imagine if you're playing football, that there's going to be multiple impacts during a game. And so they tried to measure by putting measurement devices on their helmets, tried to quantify how many of these happened over a whole season of play, and then look at the fractional anisotropy in different areas of the brain. And they found that there was a decrease in that ability of water to move through the neurons. And then they also found that it correlated with another protein marker, serum tau, which can also be associated with concussion injury. And then they also mapped this out in these couple of graphs, looking at the people at the start of the season, at the end of the season, and measuring how did like an individual person change from the beginning of the season to the end. And you can see that the overall trend is actually kind of sloping down over time. So from one season of playing, they're able to see small but subtle changes over time. And then the red line was two particular people who had more significant injuries while they were playing, were diagnosed with concussion. And so it's very hard to kind of separate those from the background players. So again, when we average these things over the large population, sometimes we can see these trends and differences. But again, for the one patient experiencing concussion, it's really hard to use this in isolation. They also looked at another area in the brain, and they looked at the average measurement compared to people who weren't playing, like just normal healthy controls versus the players in the game. And they found when they take the average of these two groups, that the average of the players is lower than normal healthy controls. But again, there's a lot of overlap between these two groups. If one group was clustered down at the bottom and one was at the top, then we'd be able to clearly really separate the groups. But there's so much overlap that, again, if you're that one person, it's really hard to say, do you belong better over in the control group or in the traumatic brain injury group? So another technique that has been looked at is resting state functional MRI. And this looks at how well correlated are certain areas of the brain. Like, are these two areas working together and are they related? Like, one example would be the language areas of the brain, that we have many different areas of the brain that are involved in processing language. And some of that is in listening, some of it's processing written things, and then some of it is planning what you're going to say, and then some of it is actually how to move your lips and get the words out. And all these different areas of the brain, even if we're not saying anything, are kind of silently talking to each other. So resting state fMRI kind of looks at those silent communications that are going on at multiple levels, even when you're sleeping, to better understand kind of what is the kind of base activity happening in the brain. And so one of the networks that we can look at is called a default mode network. And this is one, again, that is always active, even when you're sleeping. And they found that when they were looking at these default mode networks, that there are group level differences between people who've had a traumatic injury and normal controls that they could see on this type of study. And so when you get the results of these, you kind of get a heat map of what areas of the brain are active. And this is the normal healthy brain. And then this is the person who had undergone a head injury. And we can see that a lot of those areas, we're not seeing that activity in the kind of frontal and parietal lobes. And then we are seeing a little bit of activity here, but it's decreased compared to the normal healthy brain. So this is a pretty new area of research, but it does have some potential that's worth to continue to investigate in the future. This is just a bit more of the kind of same. Probably skip this. So one of the problems when analyzing some of these resting state studies is that there are so many neurons in the brain, and then to try and understand how billions of neurons are all talking to each other, it's a very mathematically complex thing to solve. And so while we might be able to look on SPECT at like where blood flow is, if we really want to say for functional MRI that this neuron is talking to that neuron and then make a map of these connections, it's very mathematically complex and has required a lot of advancement in mathematics and computer modeling. But we are making significant progress of that to kind of better understand these connections between the brain and just how they work, one in normal people, and then how are they potentially disrupted in various disease states. So one of the last areas I think I'm going to talk about is magnetoencephalography. And this is a neuroimaging technique where the patient sits in a chair and this large device is put over the head, and it basically can sense the magnetic fields that are being generated by the electrical brain activity. And these very sensitive magnometers are able to detect that. Because this is not a large electric current being generated in our brain, that's why the device has to be very tightly fitted over your head to be as close as possible to detect these very small changes. So in using MEG and looking at patients with TBI, this study of patients looked at different types of brain waves, particularly slow waves, which can be measured at rest. And these waves in certain areas of the brain correlated with certain symptoms like personality change or difficulty concentrating, emotional lability, or like kind of feeling like your emotions are fluctuating, or signs of depression. And these are thought to be related to that axonal injury that's happening to the neuron, and it's changing the electrical activity in the brain. So a review of looking at MEG and traumatic brain injury has shown that there's promise in using this as a functional imaging modality, but it's still very much confined to the research sphere. Again, not many places have this very specialized equipment, and not many people have the technical expertise to interpret it. So it's, again, in the research sphere and not really quite ready to be translated into clinical use at this time. And kind of like some of the other studies, that if we see some of these very subtle changes, we can also see them related to a lot of other things, like, medications or depression, or if people have had other prior medical conditions. So it is very hard to say that when we do see these changes, is this specifically related to the concussion, or is it just something else that's happened in life? So another technique that I work on is called cerebrovascular reactivity. And for this, we use MRI, but we're using a special sequence that measures blood flow in different areas of the brain. And so we give the patient a mask to wear a mask in the MRI, and it changes the concentration of oxygen and carbon dioxide. And so if we increase carbon dioxide, it would kind of be like holding your breath. But in the end, the result is that the blood vessels in the brain dilate. So we can kind of see how well they're able to do that and how the blood flow changes in the brain. And so we get maps like this where red is usually like healthy and normal, and the blood vessels are able to vasodilate and supply all the blood that is needed. and we have a atlas of normal controls to compare to. So we have hundreds of patients in that database. So then we can do some estimations of where do they fall on a normal within that normal spectrum, and calculate the standard deviations of the individual person compared to that normal database. And so this has been used to look at people with concussion and compared to normal healthy controls. And the thing that was somewhat surprising in this is that most of the other imaging modalities cause a decrease in whatever the parameters that we're looking at, like the fractional anisotropy in DTI gets worse, or SPECT CT shows a decrease in metabolism in certain areas. And CVR actually showed that the blood vessels in the concussed patient were more quick to dilate compared to normal healthy controls. And then the speed at which that was happening was also increased. So it was almost like the blood vessels were kind of more hyper responsive or responding faster and stronger than normal. Most of the other disorders that we've looked at, typically patients with steno-occlusive disease where like a blood vessel is blocked, usually this response becomes slower. So this was very interesting that it's somewhat different than what we've seen in other conditions. And that can be a good thing, because if we only see this finding in concussion, then we know that it's more specific for that as the diagnosis. If everything else is decreased and this is the only thing that causes an increase. But again, this is a small research study and it's not kind of ready for widespread clinical use at this time, but it does present a lot of interesting questions, and hopefully we can continue investigating that in our future research. Like I said, the same challenge with this study is that when we have real life people who have other medical conditions, we always have to be aware of how could that be impacting our test and our results. So in summary, for advanced neuroimaging, we have all these very cool different ways of looking at imaging to better understand the anatomy and the pathology that is happening. And we have very sophisticated computers that are helping us do this analysis and look in really kind of fine resolution. But at this point, we still are really only able to make a diagnosis on a group level. Like if we take 10 people who have had something happen and 10 people who are healthy controls, we can see differences when we average all those people together. But then that means that for the one person, the one patient who's trying to better understand, do I have a concussion, yes or no, based on the imaging, that we still can't say that. And so concussion is still based on the clinical assessment and clinical diagnosis. And we use imaging to help rule out other things that could potentially be confounding it. But there is no imaging technique at this point that can say, yes, you have a concussion, or no, you don't have a concussion. So that's still incredibly frustrating for a lot of people. So what can we do in the future? Can imaging solve all this? How can we do better to help if we have one person and figure out what is happening for this one person? So maybe the future might be integrating some of our structural and functional information together and integrating more other clinical data with the imaging data. Maybe some of these studies, as I said, that a lot of them are kind of in the early days. Maybe we'll get a better understanding as these progress. But right now we're still not quite there. Where have we had success? So if we look at kind of more simpler beings. A nematode, for example, only has 300 neurons in its brain. So there have been some successful models of the brain in the nematode that were able to do all the complex computational modeling, but they only have 300 neurons and we have 85 billion. So even though our computers and our mathematics are getting better, we still have a pretty big way to go from understanding everything that's happening on the massive scale that is the human brain. And so, does artificial intelligence hold any promise for the future? Will it be able to better understand some of these really complex problems? Can AI make a difference in medical diagnosis? So, there have been some studies that have looked at integrating a lot of various clinical factors, imaging factors, and then using machine learning and convolutional neural networks to try and build a more complex model to fit our kind of complex anatomy. And so for this study, they took all these various different clinical factors and looked at a very large database of patients and then kind of tried to see what it came up with. And so we took structural data and functional data, and then the AI kind of sometimes can be a bit of a black box in really understanding what it's doing, but it was able to differentiate some factors that were present in patients who had had traumatic brain injury versus normal controls. And if they tried to pare it down to an individual patient, the study was done in schizophrenia, not brain injury. But when they kind of said, does this one person, yes or no, have this disease? It was able to make the correct diagnosis 99.3% of the time. So that makes everybody really, really excited at the potential of AI. But the challenge is when we don't really understand how it got to that and what assumptions it was making. A lot of these studies show potential early on, and then we find out that there's bias in the model, or if a wide variety of patients are not represented in the training data set, then it carries that bias over into the end result. Sometimes it picks up on things that we weren't thinking about. So there was another study in radiology where it was looking at chest x-rays and does this person have pneumonia, yes or no? And when they kind of worked backwards from the result and had it kind of display where on the image is it looking for the pneumonia, they realized that it was zeroing in on the patient location up where the name, age, date of birth, all that is. And if it said emergency room, it was much more likely to say the patient had pneumonia rather than having the heat map be over the lungs and over the actual area of pneumonia. So you really have to understand what is the AI model doing to make sure that it actually makes sense. It's using variables that make sense, and also that we have considered a really wide range of patients and clinical situations so that we're not building bias into these models in the future. So some of these studies with AI or these kind of like large complex models have tried to add biomarkers in as well. And all of these could be tested in a blood sample. But again, so far, a lot of these differences are on the group level and not the individual level. But maybe if we kind of combine some of these with imaging, again, the more information we have, the kind of more powerful our diagnosis could be. Proteomics, again, looking at different proteins that are present in the blood, has shown some potential as well. And again, the advantage of these is kind of that a blood draw is pretty easy, and a lot of the labs are able to send these to specialized centers for testing, so it would be widely accessible. So maybe if we combined AI with advanced imaging and proteomics, then maybe we can take those kind of three different approaches to combine it into a diagnosis for an individual person. A big challenge, as I've said many times now, is what about if you have comorbidities or other medical conditions? How does it deal with that? So, in summary, the brain is very complex and very delicate. In concussion, conventional imaging such as CT and MRI should be normal in concussion, but that doesn't mean that these people don't have severe or persistent symptoms. Advanced neuroimaging can only see certain findings when compared to a large group of normal healthy controls, and diagnosis is not yet possible at an individual level. And then in the future, AI and advanced imaging and other areas of active research interest could change this. So routine clinical imaging of concussion, we're not quite there yet, but I think the future is bright. Thank you.
Thank you so much, Dr. Para, for a great presentation of a very complex topic. We do have a number of questions and just a few minutes left. I don't know if I know we were having technical difficulties. If you're able to turn your camera on, awesome. If not, don't worry about it. I am going to just, I'm going to start with a few
I
of the
lost my Zoom box.
No worries.
One sec. Let me stop sharing and then see if I can.
Okay, we won't spend too much time because we've just got a few minutes anyway.
Yeah, go ahead with the question.
I'll go ahead with the question. Okay, so someone is asking if their main symptoms are daily headaches and screen sensitivity, can the cause be determined using MRI? And would that change the treatment?
So the role of MRI after concussion would to be rule out a more serious injury. So we'd be looking for any evidence of hemorrhage, of diffuse axonal injury, or contusion where there's been bleed and like a bruise and then volume loss in the brain. So in MRI, we would expect with concussion that we would not see any of those findings. If we did see them, it would be classified as a more severe form of injury, such as a traumatic brain injury. But if you're having those symptoms, there's no correlate that we can see on MRI. So there's no way I can look at the MRI and say, yes, you have this, or no, you don't. And that's the most frustrating thing, is that if people are having symptoms, it kind of feels like you're not being validated, because I read the MRI and I say, well, I don't see any of these bigger things, but that doesn't mean that there's not a concussion. It's just I can't see it on the MRI.
Right. Okay, thank you. We've got someone who had an MRI, I'm assuming post-concussion, and it showed foci of high signal intensities in the supratentorial deep white matter and periventricular white matter, likely due to small vessel ischemic changes. And they're wondering what this means, if anything.
Yeah, so that's a really common finding on MRI. And I had a slide at the beginning where it looks like there are these little white dots throughout the brain. And that's really challenging because sometimes after concussion, if we have somebody who has kind of the perfect case, like say they got an MRI a week before their injury, and then we MRI them a week after their injury, sometimes we can see new little white dots. So in that case, we could say, okay, this could be related to the injury. But for most people, we have no imaging before the injury. So we have no baseline to compare to. And then we also know that because of other things in life, the biggest things would be high blood pressure, high cholesterol, diabetes, that can also cause injury to the very small blood vessels in the brain, that can result in these white dots in the brain. There's also other things that can look really similar, like people who get migraine. There are changes in blood flow. It's a different mechanism, but they can get these white dots, and those people might not have, the high blood pressure, cholesterol, et cetera. But the end result is a white dot on the imaging. And then when I'm looking at it, I can't tell what caused that. All I can say is that there are these white matter hyperintensities, but I can't say what the cause of it is. And even if you were to look, like when they've done postmortem studies looking at brains after people have passed away, even if you look at those, it kind of all funnels down to this is what it looks like on the imaging or on pathology, but it doesn't tell us what got us there in the first place. And so a lot of times when people read MRIs, just kind of the balance of probabilities is a lot of people have vascular risk factors. So it's kind of attributed to that, but it doesn't mean in your specific case necessarily that that was the cause. It's just kind of the balance of probabilities for most people. That's what we attribute it to. But again, like I said, everything kind of funnels down to making the image look the same way. And we can't say with 100% certainty, yes or no, this is what caused it.
Okay, great. Thank you. Here's a question. So in the ER, in the emergency department, do all concussed patients get a CT scan?
So it will depend on a lot of different things. So usually the emergency physician is going to do an assessment and kind of understand, what happened, how is the patient doing, like are they awake, alert, oriented? Did they lose consciousness? Are they able to speak and give a history? So there is going to be a clinical assessment at the time of injury to try and estimate how bad was this injury. Like if somebody just bumps their head on the door frame versus being in a car accident at 120 kilometers on the highway, our kind of sense of risk from that is going to be different. And so the emergency physician is kind of assess what the likelihood that they think that there could be something wrong, like a large hemorrhage in the brain. And that's usually when they do CT. Because we know if it's a concussion, the CT is going to be normal. If their clinical assessment is that it's a concussion and they're not worried about basically like a hemorrhage or a stroke or something like that, they don't always do a CT. And so it really kind of depends on what that initial situation was. And then what might happen after that, though, is if people continue to have symptoms and feel that, they do have a concussion, and maybe go see somebody after, or like their family doctor, or maybe a neurologist, or a therapist, that somebody then might refer them to MRI to see if we can see any of those kind of more subtle changes on MRI that we wouldn't see on CT. And as I said, depending on the various studies and different populations, sometimes they found 3%, sometimes they found 30%, which I feel is kind of high. But they found that there were a small portion of those people that on the CT it looked normal, but then they saw some of those kind of very subtle things on MRI. But again, the vast majority of people are going to be normal on the MRI too. So I guess it really depends on kind of what the initial story was when the injury happened. Are you presenting to the ER, or is it kind of you're having symptoms and go to your family doctor a few weeks later? It really kind of depends on a lot of those clinical things of kind of which pathway do people go getting CT or the MRI, and what imaging is done.
Okay, great. Thank you. Okay, I'm just aware of the time. Okay, I'm going to try and get a couple more in. How does imaging help change the treatment for concussions? If not, that is, if it doesn't change the treatment, then why do it?
I think the main reason to do imaging at this point is to rule out a more severe form of injury. So, particularly in the emergency room, the biggest thing that we're trying to rule out is a bleed in the brain or potentially a fracture. So, a lot of times with head injury, either a skull fracture or a fracture in the cervical spine. So, a lot of our assessment in that kind of acute emergency room is looking for big bad things. And especially if somebody is coming in and they're a bit disoriented or a bit confused, then we really want to make sure that it's not because they have a massive bleed and maybe they need to go to surgery. Um, so we're trying to rule that out. But like I said, if we don't see anything, I mean, I guess that's good that there's no large injury, but it doesn't mean that there's not those small microstructural injuries that we can't see on the imaging. So it's more of a rule out rather than a rule in.
Mm-hmm. Mm-hmm. Okay. We've got someone asking, would it be harmful to the brain to get a CT scan due to radiation to the brain? Wouldn't it be better and safer and more effective to do an MRI instead?
So CT scans do have a small amount of radiation associated with them, but it's very quite low. Um, like a lot of the comparisons will be made between if you went on a flight from here to Vancouver, how much radiation would you be exposed to versus how much on the CT? And so CT is more than an X-ray, but it would be like flying to Vancouver. A CT of your brain would be like flying to Vancouver and back twice. So in the context of there is radiation in our environment all around us on Earth, depending on certain places where you live. In the world, there's more radiation. If you go on a plane, there's going to be radiation. So it is relatively small. And so we do try to avoid unnecessary medical radiation. I wouldn't want everybody getting a CT every day. But if you have had something happen to you in your life and you're having symptoms, or like if you fell down the stairs or had a car accident, the risk benefit of having that small bit of radiation to understand if we have something like a bleed and you need to go to the operating room versus the small amount of radiation, the risk benefit would say that we'd be better off doing the CT scan. And then we are cautious in people who have had lots of imaging over time, particularly with pediatric patients, like pediatric oncology patients, where they might need to get imaging every few weeks or every month, that we really try as they're growing and you're kind of more sensitive to radiation to really use MRI more in those areas. And even with our adult patients, like the most common ones that we see at our hospital, because I read for Princess Margaret, would be oncology patients again. And we do a lot of those follow ups with MRI to avoid that radiation. But the caveat is that we only have so many machines. And in the emergency room, basically every hospital in the country is going to have a CT scanner. They're widely available. We have tons of them. We can get, if you come into the emergency room, we can take you right down to the CT scanner right away. So part of it is logistics and accessing things in a quick manner. A CT scan also only takes like, once they get you on the table and positioned, it takes like 20 seconds to take the picture, where the MRI can take half an hour to an hour. So in an emergency after like a car accident, we need a quick answer now. We can't wait an hour to get those pictures. So there's kind of pros and cons to both, and we kind of weigh all those different kind of individual patient factors and system factors, and then just the practical realities of accessing imaging and the time and things like that.
That's great. Thank you so much, Dr. Para. There was a lot of information. I'm sorry I couldn't get to everyone's questions, but there will be a survey coming your way. Please, if you have a minute or two, fill that out. If there was a question that you'd really like answered, you can include it, but just make sure that you include an email address as well so that we're able to get back to you because the surveys are anonymous. And just a reminder, our final webinar of the season basically is coming up in 2 weeks. We've got Dr. Carmela Tartaglia, who is going to be back with us, and she's going to be talking about concussion mythology and non-evidence-based therapies. Thank you so much, everyone, for attending, and have a good evening.